Hello everyone. Today we will discuss about chapter number 87 of ARASU, that is prostate diseases. So we will go in depth about the complete chapter. I would recommend you to make the notes along with me for better understanding and to recall it easily later. First we will deal about the introduction. So in introduction, most important point is prostate is made up of two things. So prostate gland is equal to epithelial cells plus stroma, and both of them are stimulated for their growth by androgens. So growth stimulated by androgens, and among these two, epithelial cells are the one which will produce prostate specific antigen and prostatic acid phosphatase enzymes. So these two are produced by epithelial cells of both types, malignant as well as non-malignant epithelial cells will produce these enzymes. Second point in the introduction is all prostatic diseases increases with age. So disease burden increases with age. This point we have to understand. That's why we commonly see prostatic diseases in elders. If we see the gland and if we consider the passage of urethra here, if we consider this periurethral part, the area of the gland surrounding urethra is called as transitional zone. So here periurethral transitional zone, this part will increase in the size during puberty and after the age of 55 years, and this occurs in almost all men. But if the size is too much, compromising the urethral urodynamics, it will lead to the symptoms of prostatomegaly. So the point here is periurethral transitional zone of prostate gland increases in size during puberty and after 55 years of age. And one more important thing is, in this gland, I told that the structures in the gland are stimulated by the androgens. So the testosterone will get converted into dihydrotestosterone by an enzyme in the gland called as 5-alpha reductase. So just to recap introduction, gland is made up of epithelial cells and stroma. Epithelial cells are the one, both either malignant or non-malignant, will produce prostate specific antigen and prostatic acidic phosphatase enzymes, and both of these will be stimulated by the androgens. Mainly testosterone will get converted into dihydrotestosterone with the help of 5-alpha reductase in the gland, and all the diseases of prostate will increase with age. So as the age advances, especially after 55 years, this transitional zone will increase in the size, leading to symptoms of prostatomegaly. And finally, when we are dealing with prostatic diseases, we have to keep it in mind that the risk of interventions, it may be diagnostic or therapeutic, risk of interventions should be balanced with the disease risk itself. Disease risk, in the sense, majority of the prostatic diseases will be less aggressive, and if they are not causing any trouble to the individual, better not to intervene much. We have to just wait and watch for the progression of the disease. So the point is, be less aggressive, treat only if symptomatic. So these are the things in introduction. Now we will deal the commonest presentation of prostatic diseases, that is BPH, benign prostatic hyperplasia. Second section is about BPH. To understand this well, we will see a schematic diagram representing three major structures, that is urinary bladder, with the urethra. Then we have to consider rectum here, we have to consider the rectum, and in between these two we will consider prostate gland. So to label them, this is bladder and the middle one is prostate, and at the end it is rectum, and this is urethra. This is a schematic diagram. Now we are discussing BPH. So as the prostate increases in the size, what happens? So we told that after the age of 55 years in men, usually prostate will enlarge. So as prostate increases after 55 years, what all things will happen? This will cause obstruction to the urinary flow. That will lead to lower urinary tract symptoms. Mainly these will be of two types. One is obstruction. So there will be obstruction to the flow. They are called as obstructive LUTS. And because of the accumulation and the obstruction, again it will lead to irritative symptoms, irritative LUTS. So for example, in obstructive there will be weak stream of the urine, there will be dribbling, and there will be sense of incomplete voiding and straining are the features of obstructive lower urinary tract symptoms. When it comes to irritative symptoms, they might complain of increased frequency of urination, and there will be increased urgency. These are some symptoms with which BPH patient will present to us. So mainly here two problems will be there. So the problems in BPH are two things. One is that this bladder outlet where sympathetic system will be acting will be overactive. So bladder outlet sympathetic tone is increased. Okay, this is called as dynamic aspect of the disease. And one more thing is prostate size is increased. So increased gland size. This is called as static aspect of the disease. So these are the two major problems. That's why when we treat BPH, we will target these two things. So again, for these problems, there will be two targets. To reduce the sympathetic tone of bladder outlet, what we will do? We have to block the sympathetic system. So we will use alpha blockers, and this static component, that is increased gland size, to prevent the increase in the size of the gland and to make it shrink, we will use 5-alpha reductase inhibitors. In the introduction, I have told there is an enzyme in the gland responsible for the growth of gland. We have to inhibit 5-alpha reductase enzyme. So these are the two targets. So with this, we got to know that as the prostate increases in size after the age of 55 years, there will be obstructive symptoms and irritative symptoms. And mainly there is problem in the bladder outlet here. Sympathetic tone is increased and the size of the gland is increased. These are the two aspects of the disease. So we are targeting here and the gland. And for this BPH, investigations are according to the symptoms. For example, we told that there will be weak stream and there will be dribbling. So the problem is in the flow of the urine, and there will be straining. This will lead to increased pressure. So to study flow and pressure, we will use urodynamics. Urodynamic studies will help in the assessment. Then we told that there will be incomplete voiding. So we will do ultrasound to see post-void residue. If it is significantly more, we can consider incomplete voiding, and we can also ask for cystoscopy to look for any structural changes, and this is also advised before the procedures for BPH. These are some investigations, and we got to know that we will target mainly with alpha blockers and 5-alpha reductase inhibitors. To see the examples of these two groups, we know that in alpha blocker mainly we can use prazosin, tamsulosin, terazosin, silodosin. So the medications like these are utilized to block the sympathetic tone so that it will facilitate the voiding. And here the examples are, we know that finasteride and dutasteride. So the dose here, commonest is tamsulosin. We can give 0.4 mg OD, some 30 minutes after food should be given, and we can increase the dose to maximum of 0.8 mg OD when it comes to tamsulosin, and finasteride 5 mg OD again. So these are the dosages used, and sometimes we will combine both, which will facilitate in targeting both the problems like bladder outlet, tone reduction, as well as to prevent the progression of the size of gland. So we can combine tamsulosin plus finasteride. That will be even more helpful. And the newer medications in the management of BPH are, they have tried with phosphodiesterase 5 inhibitors. For example, sildenafil, tadalafil. But the point to remember here is short-acting phosphodiesterase 5 inhibitors like sildenafil. When we are using that, we have to be cautious if we are simultaneously using alpha blockers, because both of them, if used together, will lead to significant hypotension. That is the important point. And sometimes all these symptoms will mimic like hyperactive bladder. Actually, both of them are different, but to handle hyperactive bladder symptoms, we will prefer anticholinergic medications. Anticholinergics. So these are the things in BPH. So when you see a case of elderly male presenting with lower urinary tract symptoms, obstructive plus or minus irritative symptoms, we have to consider these investigations, and we have to target two things utilizing two different groups of drugs, and the newer medications are here. What about surgical option for BPH? Remember one thing, surgery for BPH is considered as a second line therapy. So if the oral medications or medical management trial fails, then we can advise for surgical interventions. Just to list out few surgical options for BPH, we know that there is TURP, transurethral resection of prostate, and there is something called as TULIP, transurethral ultrasound guided laser induced prostatectomy. Remember, surgical options are always second line. What about prostatic cancers? So when we have to suspect and how to follow up that. So that is the third section of the chapter. So the point about prostate cancer. First of all, commonest site to develop a cancerous lesion in the prostate gland is peripheral zone, not the transitional zone. So the point is common in peripheral zone. We will go according to the case scenario. Elderly male has presented with the symptoms. Okay. So symptoms are there. So how to go ahead with the cancer proper? We have to ask about the family history of prostatic cancer. So ask about family history. If family members or first degree, second degree relatives are having prostatic cancer in the history, this person will be definitely at risk of developing cancer. So family history plus or minus. Then for that individual, we have to consider DRE, digital rectal examination. So DRE will help in assessing the lesion characteristics like if it is hard, nodular, irregular, and located in the peripheral zones, it might be leading towards cancerous lesion. So once these features are there, we will ask for PSA levels, prostate specific antigen. Few points about prostate specific antigen are, we told in the beginning that it is secreted by both non-malignant as well as malignant epithelial cells of the prostate gland. So this is prostate specific antigen, not prostate cancer specific. Important point here is, this is prostate specific, not prostate cancer specific. Why we are stressing on this point is, generally we will consider more than 4 nanogram per ml as significant elevation in the PSA. But many individuals who have developed prostate cancer might have non-detectable or even lesser levels of PSA, and some individuals who even doesn't have the cancer might have elevated PSA in the blood. That's why we consider it as prostate specific, not prostate cancer specific. So once we get the level of PSA and if it is significantly elevated, we have to advise for biopsy of the gland. So the biopsy should be always ultrasound guided, that is transrectal ultrasonography or MRI guided biopsy should be done. So in biopsy, we will see whether the cells are malignant or not. And once it turns out to be malignant, there are some scores to look for the stages and aggressiveness of the cancer. Commonly we will use TNM staging, and there is something called as Gliason scoring system. In TNM, we look for the spread of the disease in the surroundings, like whether it has spread to the gland capsule or not, or the surrounding seminal vesicles, and even lymph nodes, nearby lymph nodes are involved or not. So these things we will assess. After that, we have to consider one more important thing, that is check for the level of testosterone. Based on this, we can divide prostatic cancers into two things. If the testosterone level is more than 150 nanogram per ml, these individuals will respond to anti-androgenic therapy. So we will continue here. These individuals will respond to anti-androgenic therapy. So commonly, some medications such as gonadotropin releasing hormone agonist antagonists, gonadotropin releasing hormone antagonists, even estrogen derivatives are utilized as anti-androgenic therapy. So these chemical agents will lead to chemical castration, which will help in management of the prostatic cancer. But the thing is, this is not a curative therapy, and there are recurrences in about 50% of the individuals with this therapy. So in such cases, the second option is surgical removal of the lesion, that is cancerous lesion. But here few points to consider are, we told in the beginning that the interventions should be balanced with the disease risk, in the sense, if the life expectancy is more than 10 years for that individual, we can consider surgical options. If it is lesser, and if the individual is comparatively lesser symptomatic, then we can avoid these procedures. And there are numerous methods of surgeries for prostatic diseases, but in Harrison they have clearly mentioned that surgeon who is doing the procedure is more important than the method of surgery, because there will be risk of damage to the urethral sphincters leading to incontinence post-op, and if the neurovascular bundle in and around the gland are damaged during procedure, it can lead to impotency, that is erectile dysfunction. So, and there will be significant blood loss. So these are some operative and post-operative complications the individual can develop. Now coming to the second type of prostatic cancer, where testosterone level is less than 50 nanogram per ml. These are called as castration resistant prostate cancer, CRPC. Here, these lesions are very aggressive and highly lethal for men. And in medical management proper, very important things in prostate cancer management are the alpha blockers and 5-alpha reductase inhibitors. Drugs, whatever we have discussed, are not helpful in the prevention of cancer. We can utilize them for symptomatic management. And few professionals have claimed vitamin C, vitamin E, selenium in the management of prostatic cancer, but according to trials, they are not beneficial. So to summarize, in prostatic diseases, we have to balance the trouble that individual is facing because of the disease proper with the interventions which we are going to do. Because these diseases, though commonest among men, they will rarely cause troublesome symptoms. And whenever we see an individual elderly male of about 55 years, in and around 55 years, with lower urinary tract symptoms, we have to follow these steps. Ask for family history, consider DRE, digital rectal examination. In that, look for the features of malignant lesions like whether it is hard, nodular, and irregular. And if it is in the peripheral zone, again it is significant. Then we can consider for sending PSA levels. If they are significantly elevated, advise for prostatic biopsy. That should be image guided, either transrectal ultrasonography or MRI guided. Once we get the biopsy report as malignancy, check for testosterone levels. Based on that, we can consider the prognosis of prostatic cancers. So if the testosterone levels are higher, it will have a better prognosis compared to castration resistant prostatic cancers. So this is all about chapter number 87 from Harrison on prostatic diseases. Hope you got the point. I hope you have followed the lecture and made notes also. Just revise them in the same order, which will be helpful in managing BPH cases in OPDs and wards, and also for referring the individual to a urologist for further interventions. Thank you so much. See you in next video.